Up next, Steven Nissen is joined by Dr. Cecilia Linde from the Karolinska Institute in Stockholm, Sweden. They discuss cardiac resynchronization therapy produces long-term improvements in disease progression in mildly symptomatic heart failure patients. 5-year results from the resynchronization reverses remodeling in systolic left ventricular dysfunction were the REVERSE trial.
Now, Dr. Linde, you're reporting here on the extension of a previous trial. Let's briefly talk about the design of the trial and the initial report, and then your incremental findings here. So
Sure.
This was designed to do what, the REVERSE trial?
Well, this was the first study that focused on mild heart failure patients with wide QRS and to see if they derived the same benefits by CRT therapy as those with more severe disease states. We started the study in 2006, and it was designed as a parallel randomized controlled trial where everybody got implanted with the CRT, but you were randomized to have it turned either on and off. And then you were followed in a double-blind fashion for 1 year in the United States, 2 years in Europe. And the main finding of REVERSE was substantial reverse remodeling in terms of left ventricular and systolic and diastolic volume index drops and improvements in ejection fraction, though the primary endpoint, which was percentage worsened by the clinical composite, was not quite met with a p-value of 0.10.
Yeah. Just to understand these patients a little bit better, they had what severity of heart failure, what sort of average ejection fractions, and so on?
Yes, 80% of them were in function class 2, 20% of them were in function class 1, previously symptomatic. The mean ejection fraction was on the average 26%. Left bundle branch block was present in about 60%. And the QRS width was on the average 153 milliseconds, so slightly less than in previous studies of more severe disease.
So moderately severe disease, moderate QRS widths. You had planned from the very beginning to follow these people longer term,
Yes.
Is that right?
Yes.
And so you're reporting here at the European Society of Cardiology meeting on the 5-year follow-up. And this is now follow-up only in the group that actually received CRT. Is that correct?
Yes, we only focus on those assigned to CRT, and from 610 in the overall study with a 2-to-1 stratification, this amounts to 419 patients being followed in the CRT mode for 5 years.
And your ability to ascertain outcomes in those patients, were you able to follow all of them? Were there some dropouts?
Well, the compliance was 95% at 3 years and 83% at 5 years, which we thought was good in view of the long duration of the trial.
Tell us what happened after the randomized phase of the trial and the longer-term extension. What happened to these patients?
Well, the funny thing, or expected thing, I expected it, was that reverse remodeling was incremental over the first 2 years. Those results lasted over the 3 years to come with no further improvement but no deterioration. So what was achieved in 2 years and then kept.
And did it take the full 2 years to see all the benefits, or did it happen even more quickly than that?
The greatest benefits took place over the first 3 and 6 months, but then there was an incremental benefit over 2 years. And that is not just our observation, that has been demonstrated in the CARRIER-HF and other trials. But in contrast to the other trials, we have a much longer follow-up of echo parameters and with core lab evaluation over the full 5 years.
Background therapies, of course, are very important here. How were these patients treated?
Well, they had to be on optimal medical therapy, which at that time meant ACE inhibitors and or A2 blockers and beta blockers. And in fact, 96% of all patients were on those drugs. And if you were not on beta blockers, you had to state why you were not. So we were very careful in not measuring reverse remodeling by beta blockers, but that was achieved by CRT.
So in the randomized portion of the trial, everybody got optimal therapy,
Yes.
and then you continue that optimal therapy. Kind of curious, did some physicians, as these patients got better, did they back titrate the background therapy, or did they really more or less keep them on what they were on?
Well, that was what was advised over the randomized phase, double-blind randomized phase. Actually, we haven't looked into that yet. That is always tricky, but it's a thing that remains to be done, so I cannot answer that question.
But you recorded their concomitant medications and all these other
Yes,
things.
that has been recorded.
This study was funded by industry?
Yes, it was funded by Medtronic.
Yes. Obviously, when you use an invasive technique for treatment, we would want to know, I'm sure our listeners will want to know, what were the adverse effects that occurred in the group that got CRT. Perhaps you could help us understand some of the downsides.
That's a very important issue because device therapy is linked to complications. The additional risk of having CRT on top of ICD, because everybody here is indicated for an ICD, is linked to the left ventricular lead. And most of the complications that we see there is either left ventricular lead dislodgement or diaphragmatic stimulation. The 5-year rate was relatively low to 12.5%, and most of this, nearly 8%, took place over the first 3 months.
So if you got through that 2 years and then went into the extension phase, people were pretty much stable.
Yes.
In terms of battery life, some people have to have their devices replaced or not?
We haven't looked into that yet, but that is a thing. If you have these long-lasting results, as we did in reverse, that really puts the pressure on industry to have more longevity of CRT devices than is the case right now, because you don't want to do pocket exchanges for battery depletion unnecessarily.
Right. That obviously, as the years go by, more and more of your patients will have to have that done. Although, clearly if people are alive and, with a good ventricular function, that may be a relatively small price to pay. Now, in Europe and in America, relatively few patients that fit these criteria are getting CRT. What are the barriers? What can we learn from your study? How do you think we should go forward?
I think we should rebuild structures that you cannot forget about CRT and ICD therapy. It's very under-implemented in Europe. I know it is to some degree even in the United States. So I think we should use computer files asking questions. Did you consider CRT, ICD before you discharge patients and before you give them back to the general cardiologist or private cardiologist?
Some people in the U.S. have worked to try, and actually, of course, in Europe to a great extent, on trying to figure out how to select the best patients in this group to be treated. Do you have any insights from your trial? Were there predictors of who was going to do well and who wasn't, and what can we learn from that?
Well, what we learned from the reverse and from other trials is that patients with dilated cardiomyopathy as opposed to ischemic cardiomyopathy are overall less sick and do better in terms of reverse remodeling. But that's not to say that ischemic patients do not benefit. The ideal patient for CRT is a female with dilated cardiomyopathy and left bundle branch block. Yeah. And that's interesting because it's precisely the women that do not get it if you look at the implantation pattern both in the United States and Europe.
This gender difference is fascinating. And do you have any insights as to why that might be the case?
I think you need to do a case-to-case meta-analysis to be really sure, is it the gender per se, or is it the fact that women more often have dilated cardiomyopathy linked to left bundle branch block? I don't know. That's an open question. I think you have to look on a case-to-case basis and do a meta-analysis. So
let's look at the bottom line. Although I'm not a big proponent of ejection fraction as a measure of ventricular function, you started out at 26, 27%, 5 years ago. Follow these people for 5 years. Where did they on average end up at the end of the study?
Plus 6%. It might not seem such a big thing, but remember that the 5-year mortality rate here was 13.5%, which is remarkably low when you compare it to heart failure drug studies on patients with similar disease condition. So what this means is you add CRT on top of optimal medical therapy, you gain something.
You gain a lot. Fascinating, terrific study to have 5-year follow-up, and my congratulations. And thank you for bringing our listeners up to speed.
Thank you.